minimizing adverse effects with acupuncture. Okay, so when we think about adverse event, what do we mean by an adverse event anyway?
Causing pain.
Yeah, right. Something that may be associated with the treatment that may be, adverse or uncomfortable. That wasn't like an intended outcome of the treatment. So that's what we're going to talk a little bit about, how do we minimize those with acupuncture treatment. So, acupuncture in general, very, very low risk of adverse events and very few complications. So it's got low risk. They've statistically much lower risk than many standard medical treatments. Okay, kind of the minor adverse events that we associate with acupuncture, things like pain around the site of needling, tiredness, fatigue, right? That's not uncommon report after acupuncture treatment. Bleeding, bruising that can occur anytime you penetrate the skin with the needle. There's always the potential for a little bruise to occur. There's always the potential for some blood to be expelled, so there's always a chance for that to happen. More uncommon, slightly more serious adverse events, things like feeling faintness, right? So feeling of faintness, not even necessarily actually fainting or passing out, which in fact is very uncommon, okay? But you do see people report sometimes after acupuncture like a feeling of lightheadedness or dizziness or something of that nature. Stuck needle, meaning the needle being unable to be removed from the site of insertion again. Injury to peripheral nerve. Needles that are not removed. So again, if the practitioner himself, leaves a needle in place and then the patient leaves the office with the needle in place. Pneumothorax, right, damage to the lung, or local infection. Okay, so pain around insertion. So the ways to minimize pain around the insertions, typically, palpating for subcutaneous structures, because again, if you impact something like a tendon, muscles, bones, deep insertion, that's going to be more uncomfortable. Tough connective tissues tend to be more uncomfortable. So, palpating and locating those tendons, like when you're needling, especially say, for example, along the pericardium channel or something where the tendons may be a little closer to the surface. So palpating for those structures, you can help to avoid those structures and avoid pain. Knowing where major arteries and veins are, of course. Again, palpating for those structures too, like you can feel the pulsation of the artery under the skin, if you can see visibly the artery on top, near the surface of the skin. Typically, you might cause more pain if you strike one of those structures. So, for example, what might it feel like, do you think, if you were to needle near or into, say, a vein or a small blood vessel or something like that?
Like a acute, pricking sensation, like maybe burning?
Yeah, so that's actually correct. Like a lot of the times when you nick or needle too closely to a small blood vessel or something like that, you might feel like a mild burning sensation or something of that nature. Needling into things like nerves or tendons, often you're going to feel more like a paresthesia, so you might feel like a numbness or a shocking sensation. So again, if they felt those sensations, say, oh, okay, this may indicate that we're too close to one of these structures. The other thing that they recommend and have found in studies is often pain around the site of insertion will be associated with not letting alcohol that was used to swab the skin dry. Again, if there's a lot of wet alcohol there penetrating the skin, and then you have alcohol that's going to leach into that wound, and it's going to be uncomfortable. Right? So when you swab this point, let the alcohol dry completely before you needle. That reduces pain. Special care on scalp and ears and other places where there's a lot of nerve endings. So of course, anywhere on the face, scalp. Again, often we know things like Jingwell points, tips of the fingers, that kind of thing can be slightly more uncomfortable. And then also limiting needle manipulation. A lot of the times when there's a lot of strong pain associated with acupuncture, there was a very intense needle manipulation. Okay, so limiting needle manipulation tends to make it less painful or less uncomfortable. Bleeding, right? Again, always a possibility when you're penetrating the skin with the needle. So again, avoiding needling directly into arteries or major blood vessels. So you want to have good anatomical knowledge and identify points that might be near or over blood vessels or arteries. So what are examples of those points that we might think of that are commonly near blood vessels or over arteries?
Stomach 9.
Yeah, stomach 9, right? Carotid.
Brachiophallic vein.
Yeah, so maybe some areas like, pericardium 3,
Yeah.
right, or heart 3, maybe. What's a couple of really common points, distal points that we might look at over?
Oh, the stomach 42?
Yeah, stomach 42, right, Chongyang, or the dorsus pedis, or lung 9, or is another one we often think of, right over the radialis. So, being aware of the local anatomy will reduce your risk. I had a teacher in school who used to talk about, he said, know the risk means no risk. So maybe not no risk, but the more aware you are of the risk, the more you can manage it and the less there's going to be a problem. Again, palpating before needling, pressure after needling, so on removing the needle, applying pressure with the clean cotton in order to staunch any bleeding that may occur. The other thing you might want to do, again, asking patients about medications or supplements that might increase bleeding risk. So if they're on, even things like daily aspirin, or of course things like warfarin or Plavix, right, is the thing that they're kind of using to replace a lot of the warfarin and stuff nowadays, and those could cause more likelihood of bleeding. Fainting, again, not common for people that actually faint during acupuncture treatment. More common for them to report sensations of lightheadedness. Interestingly, when you read the 7th edition manual, they say that studies report more people report sensations of faintness or lightheadedness than actually faint. A study by Witt found that about 0.72% of patients have some sort of vegetative symptoms, right? So they feel a little bit lightheaded or dizzy, but only 0.027% actually faint. Okay, so it's not that common, all right? The number one things to reduce risk around that, the main risk around fainting is actually a fall, right? And so if you fall, that can actually have a lot more serious consequences. So they often will recommend first treatments being a person being supine, right? Just laying on the table. If they did feel dizzy or lightheaded or did pass out, then they're not going to fall because they're already supine on the table. Recommending patients to eat before treatment. You want to make sure that a person doesn't have like very low blood sugar or something like that before they're being treated. There's also symptoms of fainting in that sense of dizziness or maybe feeling nauseated. They may start to get kind of pale, pallor in their complexion. In the action, we have these posted in all of our clinic rooms. You guys probably seen, so we have the recommendations for treating what they call needle shock, right, or pre-syncope. And so, remove the needles, have them lay flat with the legs elevated. You can apply acupressure to GB26, right? Bring them back to awareness. Pericardium 6, they do also sometimes recommend, especially if they're experiencing palpitations or nausea, right? They say if the needles are located mostly in the upper half of the body, you can apply stomach 36 too. If the needles are located more in the lower half of the body, you can apply LI4, and that can help to reduce those feelings of pre-syncope. Stuck needle. So this is again a needle that is difficult to remove. Okay, won't come out easily after insertion. Kind of the main ways to avoid stuck needle is through proper depth and stimulation. So like if you're doing, so what are examples of a stimulation that might cause something like a stuck needle, might be more likely to cause stuck needle?
All I could think of is if the patient moves after the needle's been inserted.
Yeah, so often we'll say, say patient in a relaxed position. So they'll recommend, don't move after the needles have been placed. It's good because it could cause shearing or bending of the needle, or tightening the tissue around the needle. And so we usually recommend people to stay still. The other one is like they'll recommend not to, if you do rotational stimulation, to rotate in multiple directions, right? So don't just like twist in one direction for a long period of time, as that can wind connective tissue fiber in the needle and make it difficult to remove. So if you have a needle that's difficult to remove, turn in the opposite direction. So if you had been doing rotational stimulation, turn it in the opposite direction that you've done rotation. Sometimes even just like wiggling it back and forth, a little bit will loosen it up. You can also just wait. Sometimes you'll try and remove it and it'll be stuck. And then if you wait until the patient, just rests on the table for a few more minutes, or like remove additional needles, and then come back, and then the needle will be easier to remove. Or you can massage or tap the area around the needle, and that can sometimes release any like muscular tension that may be causing the needle to be stuck in place. Failure to remove needles, so this would be essentially the practitioner leaving needles in place as the patient left. So always remember to count needles, okay? And what might you think of as high likelihood of places where you might leave needles?
In the hair.
Yeah, anywhere there's hair, that's not uncommon, especially if there's a number of needles on the head. It's because you can't see them. Remember, like male patients that have a lot of body hair, sometimes it's easy to kind of forget where you've placed a number if there's a number of needles. So count the needles in and then count the needles back out again. The other ones I found are sometimes like on the sides of the chest, right? Or like if you needle something like liver 14, sometimes you can get away with needling liver 14 in a woman that may be wearing a brassiere or something like that, or you may not have her like completely disrobed, so you might just lift the shirt and place the needle. Have it roll up the shirt and then place the needle, and sometimes like if you're not cautious, it's easy to leave that needle there in place just because, it's like just underneath of where the lip of the shirt is resting or something like that. So always count the needles in, count the needles out, remember where you've placed them. And then they also recommend, we don't typically have like acupuncture assistants in the United States, but same practitioner should remove the needles as inserted the needles to minimize the chance that those needles will be left in place. Pneumothorax, again, this is a very uncommon risk of acupuncture. So pneumothorax, what is a pneumothorax anyway?
Puncturing the lung.
Yeah, so essentially it's defined as abnormal presence of air in the space between the lung and the wall of the chest, so like in the pleural cavity. And this prevents the lungs from being able to expand. Essentially there's like a pocket of air and then the lung can't fill up the chest cavity correctly. And so thinking about pneumothorax, we usually associate it with penetration of the chest cavity, deep insertion of needle. What might make somebody more likely to have pneumothorax in general?
Really thin body frame?
Yeah, typically thinner body frame, right? More gracile individuals, there's less tissue, right? So in terms of needling. Also, they find like in general, there's a rate of what they call primary spontaneous pneumothorax. So in general, the rate of primary spontaneous pneumothorax is just for some reason they get that air in the pleural cavity that causes the lung to be unable to expand. And the rate of that happens about 7.4 out of 100,000 men per year, just without any injury, without any other complication. And for women, it's a little bit less, like 1.2 per 100,000. And things that can increase the chances of things like that happening though, are like COPD, like chronic obstructive pulmonary disease, histories of smoking, histories of other lung disease, can make that a little bit more likely, okay? And so the things that we want to think about when we're talking to patients would be like, know their history. Do they have COPD? Were they a history of smoker? Have they ever had a pneumothorax before? Again, assessing their physique, relatively thinner people that have, less tissue, it's going to be easier to needle that deeply. And then again, we abide by appropriate needle angles, right? So like, you angle obliquely as opposed to perpendicularly, especially over the back, the back and the chest. We limit things like vertical manipulation in those places, so we don't want to do a lot of deep lifting and thrusting, stuff like that. What are points do you think that might be relatively riskier for pneumothorax?
Gallbladder 21?
Yeah, gallbladder 21, which in fact is the one that has even though the rates of pneumothorax are very low, that is one of the points that, especially in China, they recorded as being more common with pneumothorax. And I think it's largely because there's the lack of awareness sometimes that the apex of the lung can reach up above the clavicle. And so you think you're in a safe place, but no, actually the lung can come at that far. And so that's kind of one of the higher risk points. Also things like stomach 12, right? Stomach 11, potentially. And then, of course, any of the points in the chest, like kidney points, stomach points that are in the chest, points like the back shoe, right, or points over the back, and above the level of like T12, right, it's going to be potentially causing pneumothorax. All right, I think that's good enough for now. We're not going to be able to post more.
Yeah, this is 15, although that was